This first slide shows the phenotype of MSCs growing as adherent cells in standard tissue culture flasks. You can see these broad, flat looking fibroblast type cells that proliferate and divide and grow on the plastic surface of the flask. MSCs were evaluated in a position paper published by the International Society for Cell Therapy, and they defined the minimal criteria for defining multipotent mesenchymal stromal cells. These were defined as plastic adherent cells which were expressed surface markers including CD105, CD73 and CD90, but were negative for CD45, CD34, CD14, CD11b and other mature cell markers. In addition, the MSCs must have the capacity to differentiate into the three lineages of osteoblasts, adipocytes and chondrocytes in vitro culture. MSCs have been shown to secrete a number of growth factors and cytokines. This slide just shows a short list of a number of these cytokines and growth factors, including a range of interleukins, the colony stimulating factors including macrophage colony stimulating factor, granulocyte colony stimulating factor or Neupogen, and granulocyte macrophage colony stimulating factor. Also early acting factors including leukemia inhibitory factor, stem cell factor and FLT3 ligand are all produced by MSCs. The MSCs support the growth of hematopoietic stem and progenitor cells in vitro, and this was the basis of the long-term Dexter culture described many years ago by Mike Dexter and his colleagues. Also, Connie Eves used MSCs as the basis of long-term culture initiating cell assay, or the LTCIC, which has been a standard for evaluating more primitive hematopoietic stem and progenitor cells in culture. In the bone marrow, the MSCs form the microenvironmental niche for hematopoietic stem cells and are key in the homeostatic maintenance of blood cells. This slide shows the cartoon of depicting the bone marrow microenvironment and showing the close proximity of hematopoietic stem cells, which can be seen in the enlarged area here, showing hematopoietic stem cells closely related to the supportive stroma, and these hematopoietic stem cells have the capacity to differentiate and form lymphoid and myeloid elements and also platelets and red blood cells. The stromal cells have the capacity, as mentioned earlier, to differentiate into other cell types including osteoblasts, adipocytes and chondrocytes. And so this mixture of cells is closely related to the bone matrix, and there are blood vessels integrating through the stromal support. This slide shows you an in vitro culture with the MSCs shown here as the flat adherent cells. In this picture you can see cord blood derived hematopoietic cells which are actively proliferating on the MSC. So this has been the basis of clinical trials looking at the ability of MSCs to support expansion of cord blood cells. But what you can see is the close relationship for the support of the proliferation of the cord blood stem and progenitor cells by the MSCs. Another important property of MSCs is the secretion of an immunosuppressive factor. Patients with severe graft versus host disease have been infused with haploidentical MSCs, and this has resulted in the resolution of the graft versus host disease. These patients were steroid resistant and had grade 4 graft versus host disease, and without resolution would have most likely progressed to die. So that this has the major potential to shut down T cell responses through this immunosuppressive factor and can offer therapeutic benefits to patients. This effect is shown in this slide, looking at mixed lymphocyte reaction. In the presence of allogeneic peripheral blood mononuclear cells, T cells have the capacity to proliferate. This is shown by incorporation of tritiated thymidine. If MSCs are added to the mixture of the peripheral blood mononuclear cells and T cells, you can see that the T cell proliferation is totally suppressed. And so again, this has been the basis of measuring this immunosuppressive effect. This slide shows you a typical process for manufacturing MSCs. These were products that were manufactured at the University of Miami. These are manufactured under GMP conditions. A bone marrow aspirate is obtained from a patient or a donor. The mononuclear cells are isolated using Ficol gradient separation, and then the mononuclear cells are placed into culture flasks. In this case we used 10 T162 centimeter squared CoStar flasks. It takes about 2 weeks for these P0 cells to become confluent in these flasks. The MSCs are then harvested using standard trypsin treatment and then expanded into more flasks, which are then further cultured, and after 3 to 4 weeks of culture the P1 cells can be harvested. Our initial target for manufacture was 250 million MSCs. A typical expansion is demonstrated in this slide, starting with 25 mils of bone marrow. The starting cell count of 588 total nucleated cells. The mononuclear fraction represents a fraction of the total cells, and through this mechanism we generated over 500 million MSCs. For release testing, this is taken from an Osiris preparation, but these are standard tests including sterility, endotoxin, mycoplasma. Obviously we want viable cells that are able to stay alive once they're infused. The cell concentration is determined, and purity is often determined using FACS analysis. Classically, the MSCs are defined as CD45 negative and CD105 positive, and other markers such as 166 can also be evaluated. You can see here a highly purified preparation being 166 positive and 105 positive, but negative for CD45. There are a range of sources of stromal cells which have all been termed MSCs. Whether or not they are all identical we'll discuss further in this presentation. But the different sources of MSCs include bone marrow, adipose tissue, cord blood products including the cord blood itself, and other aspects of cord blood, the cord tissue, placenta tissue, Wharton's jelly, amniotic fluid, and a range of other organs and tissues including cardiac tissue, liver tissue, and basically all cell tissues and organs of the body have a similar population or a stromal population. This slide just shows you some variability that has been reported comparing the flow phenotype from bone marrow to cord blood to adipose tissue. The classic markers are highly expressed in all these sources, including CD73 and CD90. You can see a greater than 90%, typically around 99% expression. They all have expression of CD105. Some variability does exist if you look here at CD34. Bone marrow has low expression of CD34, as does umbilical cord derived MSCs, with slightly higher levels in adipose tissue. This slide just is a summary of some of these antigens expressed, and you can see that the median fluorescent intensity also varies, so that the expression levels on individual cells is also potentially different here we're comparing adipose compared to bone marrow, and there's variability. Other reports have also looked at, this is looking at ascites fluid versus bone marrow, and some of these data suggest that some of the ascites fluid MSCs express more pluripotent markers, including OCT4, NANOG, and SSEA4, suggesting that there might be differences in the potency of MSCs or stromal cells from different tissues. Another marker that's been used to identify MSCs is an antigen called CD271. This is the low affinity nerve growth factor receptor. It belongs to the low affinity neurotrophin receptor and TNF receptor superfamilies. When bone marrow cells are isolated based upon expression of CD271, so antibodies to 271 highly enrich for CFUF and form MSCs. This is a typical CFUF colony, and you can see the fibroblast-like nature of these colonies, and the majority of the CFUF activity from marrow cells is isolated in the CD271 population. This is just looking at flow analysis of CD271 expression. Here you have the CD45 negative CD271 positive population, which is where the MSC activity exists. After selection with CD271, you can see that there's a enrichment of this population, but there's also a large number of the CD271 positive cells that are CD45 positive. So the MSC activity again resides in the CD271 positive, CD45 negative population. When we isolate the CD271s, looking at a cytospin of these cells, you can see these are blast-like cells that resemble CD34 positive cells. So these have a more primitive blast phenotype and resemble a more primitive cell. Certainly after culture in expansion in culture, these cells take on a more differentiated phenotype. We've also looked at the ability of the CD271 cells to generate osteoblasts and adipocytes, and so this slide just shows CD271 derived MSCs showing their osteoblast potential and also the adipocyte potential. And they also contain chondrocyte potential. So they meet the criteria that would be from the ICT position paper for classic MSCs. I'd like to spend a bit of time just discussing some of the applications, and just as an example, use cardiac disease as one of the applications where MSCs are being evaluated for their potential in regenerative approaches. Osiris undertook several trials looking at the safety and potential efficacy of allogeneic-derived bone marrow-derived MSCs, which they call Provocel. This was a placebo-controlled study in patients who had following an acute MI. It was a randomized double-blind placebo-controlled trial and was dose escalation looking at 0.5, 1.6 and 5 million MSCs per kilogram. 60 patients are enrolled and 53 subjects treated at 10 different sites. The summary of these trials demonstrated that the MSCs were safe, and there was provisional efficacy demonstrated, which include improvement of left ventricular function, electrical stability, improved pulmonary function, and an improvement in global health status in patients with acute myocardial infarction. The MSCs in these studies were infused intravenously. This led to a second large phase 2 trial, which consisted of 220 patients, double-blind, placebo-controlled, and randomized 1-to-1 prochimal or MSCs to placebo. Again, the primary endpoint was safety, and other functional endpoints were secondary endpoints. The phase 2 study is continuing, and the data from this large trial is expected to be reported very soon. Other studies have looked in animal models, and this is just a published report from Amato and colleagues, which looked at the effect of treating pigs that had an MI induced and the ability of MSCs to minimize damage to the cardiac tissue. Here, if we look at ejection fraction, you can see animals that received an MI and received placebo treatment had a decrease in their ejection fraction due to the MI, and this persisted long term. In contrast, the animals that were treated with MSCs had an initial decrease in their ejection fraction, but the heart performance improved over time with a significant increase compared to controls at 8 weeks post MI. These animal studies have led to several clinical trials at the University of Miami. These are studies being conducted by Dr. Joshua Hare. In this study, there was MSCs were injected into patients who had ischemic cardiomyopathy and who were undergoing CABG surgery. These patients had low ejection fractions. Autologous MSCs, which were injected surgically. It was a dose-finding phase 1 study, and the first patient was injected back in 2008. This is just a summary of this study. The patients were randomized and had a bone marrow aspirate. The cells were generated, and then at the time of CABG surgery, there was intramuscular injections consisting of either placebo, a low dose of MSCs of 20 million cells, or a high dose of 200 million MSCs. The slide just shows the MSCs being injected directly into the infarcted area of the heart at the completion of the CABG surgery. So the patients had a bone marrow aspirate taken. The MSCs were generated in one of two doses, either 200 million or 20 million, and then the MSCs were frozen in liquid nitrogen. At the time of surgery, the cells were injected directly into the infarct area and consisted of 10 injections of 0.5 mils at 40 million MSCs per mil, or the patients received placebo. This slide just summarizes some of the initial observations. One of the complexities of this trial was that many of the patients required CABG surgery, were unable to wait for the production of MSCs. And I present this just to make the observation that although we would consider autologous MSCs safer to use, there are many clinical settings where the patient's disease or the treatment that they're undergoing prohibits the generation of an autologous product, and in this case an allogeneic product may be better suited for this particular patient population. There are other complexities with the delivery of concentrated cell products. 40 million cells per mil can result in clumping of the MSCs, and then delivery of the cell doses offers challenges with losses with thawing and washing, losses with transfers to syringes, elimination of air bubbles, and loss of cells at the injection site due to the movement of the heart tissue. The second trial was undertaken at the University of Miami, and so this was asking a critical question. This was in patients who had a prior MI. A bone marrow aspirate was taken again, and the cells, MSCs, generated, and these were the MSCs were injected in the cath lab, comparing placebo to a dose of 200 million MSCs to a dose of up to 200 million bone marrow mononuclear cells. In this study, a catheter was used to deliver the the cells directly into the infarcted area of the heart. This is the biocardia catheter. It has a corkscrew needle, so that this corkscrew needle can lock onto the tissue, and so as the heart is beating, the needle is not rejected from the tissue. This locks the needle onto the tissue, and the cells can be injected directly into the infarcted area. So this study was a comparison of autologous bone marrow mononuclear cells versus autologous MSCs. It was a phase 1/2 safety study, and the study received approval and opened in 2008. A subsequent study was also opened called the Poseidon study, and this was established to compare autologous MSCs to allogeneic MSCs. This was a dose-finding safety study increasing from 20 million to 100 million to 200 million MSCs. It used catheter delivery in 10 injections at 0.5 mils. Enrollment has completed in this study with 30 patients enrolled, 15 enrolled to autologous MSCs and 15 to allogeneic MSCs, which included 5 patients at each dose with each cell type, and then subsequent follow-up. The conclusions from this study demonstrated that ischemic cardiomyopathy, the transendocardial injection of the allogeneic and the autologous MSCs was possible compared to a placebo control, and it was associated with low rates of treatment-emergent serious adverse events, including lack of immunological reactions. In aggregate, the MSC injection favorably affected patient functional capacity, quality of life, and ventricular modeling. And this study was published last November in JAMA. An interesting question that we've been evaluating is looking at the different stromal cells from different tissues. A question that we raised based upon the use of MSCs in the cardiac setting was the comparison of cardiac stromal cells to bone marrow stromal cells. And basically, are cardiac-derived stromal cells the same or different to bone marrow-derived stromal cells? Part of the reason to ask this question was to replace stromal cells in the heart with bone marrow-derived cells could create complexities, and so this was meant to, at a first pass, evaluate the similarities or differences between these two sources of stromal cells. When we looked at the phenotype of cardiac-derived stromal cells, the phenotype is very similar to that of bone marrow cells, being positive for CD73, CD90, and CD105. These were also negative for CD45. We did a comparison in microarray analysis and demonstrated that there were significant differences in expressions of a range of cytokines and cytokine receptors, with increased levels of a number of more muscle-derived or endothelial, epithelial type cytokines and receptors in cardiac-derived stroma. Also, cell adhesion molecules varied between the two cell types, and a number of focal adhesion molecules. Again, a number of these associated with muscle-derived cells as opposed to bone marrow cells. We also looked at microRNAs, and in this slide you can see a number of microarrays were overexpressed in the cardiac stroma compared to the bone marrow stroma. MIR1, MIR133A, and MIR206 were two that were very highly expressed in cardiac stroma compared to bone marrow stroma. Of interest, when we look at the function of these particular microRNAs, they've been described as critical factors in skeletal and cardiac muscle development, so this would be consistent with a cardiac-derived stromal cell versus a bone marrow stromal cell. So in summary, these initial studies demonstrated that cardiac stromal cells express different microRNAs distinct to bone marrow-derived MSCs. The highest expressed microRNAs have been identified as important in muscle cell development and differentiation, and MIR-206 has been reported to inhibit tumor cell proliferation. So we wanted to evaluate this tumor inhibition in more depth, and so part of this we took a functional evaluation between different stromal cell population. Obviously, the interaction between stromal cells and tumor cells is known to play a major role in cancer growth and progression. So to estimate the functional differences between the two stromal populations, we looked at their effect on cell proliferation, and the proliferation of various tumor lines was studied in the presence of bone marrow-derived MSCs and cardiac-derived stroma. Our studies demonstrated that the cardiac stroma were able to block proliferation of tumor cell lines, whereas, as reported extensively in the literature, MSCs actually supported the proliferation of tumor cells. This slide shows some of this data. In the absence of MSCs, you can see that a tumor cell line, K562, which is a myeloid cell line, these cells proliferate to some extent, but in the presence of bone marrow-derived MSCs, you can see focal points where the cells are actively growing and proliferating on the MSCs. In contrast, when we put either K562 or another tumor cell line, HL60, in the presence of cardiac stroma, you can see that there's minimal proliferation of the tumor cells. In the absence of the cardiac stroma, extensive proliferation of these, as would be expected, and this proliferation again is supported by bone marrow-derived stromal cells, or MSCs. We further evaluated this in a number of other stromal cell lines derived from other tissues, including liver stroma and adipose MSCs, here comparing the growth of K562 cells at different time points, day 6, day 10 and day 15, comparing bone marrow MSCs where the tumor cells proliferate extensively. Liver also supports the growth of the tumor cells, as does adipose MSCs, and in contrast, the heart-derived stromal cells actually inhibit the tumor cell growth. If we look at this in terms of cell numbers, you can see here again active proliferation in the absence of stroma and in the presence of bone marrow, liver and adipose stroma, while the cardiac-derived stroma, there is active inhibition of active proliferation of these cells. We've also looked at the effect of stromal cells on proliferation of hematopoietic cells. Here we've used cord blood-derived CD34 positive cells. What you can see is that these cells, in the presence of growth factors, will proliferate. In the absence of stroma, we get an increase in cell numbers over a 14-day period. This is supported by bone marrow and adipose. However, both the cardiac and the liver-derived stromal cells, there's minimal support of the CD34 proliferation, actually suggesting that there's inhibition of the proliferation of these cells. We looked at the removal of the cells from the stroma after 7 days of culture. So these cells were on the stroma from 0 to day 7, and then removed from the stroma for the second week of culture, day 7 to 14. And here again, you still get minimal proliferation, suggesting that there's an inhibitory effect on early cells, early hematopoietic cells, during this second week of culture. So in summary, our data suggests that stromal cells are essential for homeostasis of tissues and organs. The stromal cells support the survival, proliferation and differentiation of tissue-specific stem cells. and stromal cells have the potential to facilitate repair of damaged ischemic tissue. Stromal cells from different tissues are phenotypically similar but have different functional properties. This suggests that repair of different tissues and organs should be performed utilizing stromal cells from the damaged tissue. The potential of stromal cell populations in regenerative medicine requires carefully designed clinical trials, and we believe that this will lead to repair of damaged tissue and improvement in disease in many patient populations. This concludes this presentation. Thank you very much for your attention.